All right, we are back talking about ACL, mainly post-op.
Mainly protocols.
Yeah.
And the differences and
definitions
what we should do. Definitions.
Debates.
Debates. Healthy debates.
Great debates.
Discussion debates.
Okay, we really didn't debate that much, guys.
No, not really. At least not on air.
One section.
Some punches were throwing off air, but that's different.
Don't worry, I won. Those are my guts.
Anyways, let's dive into some ACL protocols.
Let's I forgot what I was gonna say. Let's proto crawl into this segment.
Wow. Hope you guys are enjoying Laura's little attempts to segue into the intro.
You ruined my segment. So let's protocol into the next part. Let's go.
The PTA podcast with your hosts, Ken
and Laura. Thanks again for joining for another exciting episode. Okay, let's go ahead and run into it. I don't know.
You could have used jump.
Yeah, but I use jump a lot. So.
But this one actually relates.
I know, but so does running.
I mean, true.
But we are going to talk about ACL protocols like we said, and we are mainly going to kind of focus on the fact that I didn't really realize there was 2 protocols for non-operative and post-op. Did you?
I did not.
I don't think the non-operative is used that often.
I feel like a lot of the non-op is for people who just said like they're not going to be super active anymore, but let's just not make it worse.
Yeah, and I feel like
does it still follow is there a difference in the non-operative one whether it's a complete tear or a partial?
It didn't state.
So if it's just torn,
yeah, regardless
of the degree.
Yeah, it didn't state in it. And then the other thing to me was the fact that you start reading it, and I feel like in our world, it was a lot of common sense, if that makes sense. Like, gain a pain-free range. Start with quad sets and glute sets and sets. And
that's between the non-op and the regular.
That's the non-op. Just talking about just the non-op.
Oh, okay.
So, like, I felt like a lot of the non-op is stuff that just kind of goes in general with an acute injury. The only thing I would say is the non-op brought up is just making sure that you are focusing on their knee buckling.
A little bit like focus, think about it.
I know, I had to think hard on it. So it was talking about like just being aware of like if the patient continues to have increased or the amount of knee buckling doesn't decrease, that is something that you just need to be aware of. So that's kind of what I found. Now, we did some research on different protocols because really you should be getting the protocols from the doctor. However, we all know that does not always happen.
It's quite frustrating when it doesn't.
Yeah.
Because they're like, which one do you want me to follow?
Right? Because as we learned, there are some that are very conservative. And literally, you wouldn't be doing anything until like the 12-week mark.
Essentially, yes.
And then there's some that are more advanced and less conservative in a weird way.
And we kind of touched on that too on our. So this is a follow-up ACL episode because we kind of touched on it already on the repairs. And one of the more forward-thinking ideas was when to perform, or if you should perform, open kinetic chain exercises. So your long arc quads, short arc quads, hamstring curls, activities like that, and whether or not it should be avoided. You have some protocols where it's like, nope, don't do that at all, and just wait, versus having some protocols like, oh, it's okay to start doing it earlier on at the 4-week mark, and so on and so forth. And when I was discussing this with my PT as well, because I had one that didn't have an opinion on it. However, the second one had a very strong opinion on it. And it kind of just came down to if it's something that isn't going to be super detrimental, why would I add more strain to the ligament? So it's like, okay, well, open kinetic exercises may put more stress on it or might not put more stress on it. But why am I going to test that, potentially have something go wrong, and then I'll piss off the surgeon at me?
Yeah.
So it kind of came down to like, nope, I'm not for open kinetic because there's
I've
just not enough on it.
I've never gotten that with ACLs, and maybe it's just something I've never comprehended or really thought too much about, but like, why is it that open chain is such a big kind of no-no?
Because of the amount of stress it puts on the ligament.
But what if you're doing open chain with a brace?
Then you're safe, I think. I don't know.
That's where I was just like, okay, well,
can you give me an example of an open chain with a brace?
Well, for example, those braces don't, like, you could do hamstring curls with it.
Mm-hmm.
Standing hamstring curls with the brace. You're still starting to work the muscle, but you're protecting it at the same time. And those braces, like, they have the locking mechanism where you can't go past a certain one, so you can do you can do it within that range of motion that's given at the same time.
Well, because that's the weird thing. So, like, on the conservative side, it's no open chain at all.
Yeah.
Versus the kind of the more middle ground, I guess, is between 90 and 45 degrees of extension.
Mm-hmm.
You're able to do that long arc quad. So I agree, just lock out the brace at 90 to 45.
And you're good to go.
And they theoretically should be safe.
Yeah, because I think the big thing for me is usually definitely post-op, open chain is more tolerable for the patient to perform as they start to strengthen. Because, weight bearing can be sometimes not so fun. We'll just put it that way.
Not so fun.
I'm not saying all, but I'm just saying a good chunk. So, like, I feel like you could start strengthening a little bit sooner if you kind of had that option in a way. But, like, I don't know. Like, the concept, I just, like, in my head, I'm like, I think I just need to go back and look at the physics of it all, honestly, and the levers and the pull and the tug. And I'm like, why is it that open chain is so much, and like the surgery, maybe it's because I don't comprehend exactly
maybe
the
what's
surgery.
happening in the surgery.
Yeah, that I'm like, why is it that open chain is causing more stress than closed chain?
So that's actually the article that I was talking about last time.
Mm-hmm.
Brings that up. Okay. So they were bringing up like how much stress, and they're bringing up like articles and research and stuff on doing a closed chain like mini squat with even a little bit of weight is not that much more stress than a long arc quad.
Yeah.
So it's like, why are we avoiding these exercises that could benefit and isolate quad strengthening when what you're claiming for the stress is negligible at this point?
And that kind of rolls into one of the second points we wanted to talk about is protocols. And definitely, I don't know with ACLs, comparing some of these ACL protocols that we found. Do protocols need to be adjusted? Because I feel like a lot of times doctors don't adjust their protocols. Like, for example, the universal precaution rule for hips. We know so many patients don't follow them. They've done studies on whether or not they were reminded or not reminded, and there was no difference.
Yeah, we still have protocols.
Yeah, we still have those protocols. And it's like, okay, well, do we need to adjust our protocols correctly? Because why are we limiting certain ranges or motions if it's not necessary? Like, I get it's kind of one of those things where, like, well, we don't want to find out, but if studies have been done,
if it's not broken, don't fix it.
Yeah, but at the same time, is that the best way of doing it, though?
No, because I agree. Like, I think you were mentioning earlier too, like, as our surgeries get better, as our technology gets better, shouldn't our protocols keep up with that technology?
Yeah.
And you have some protocols, like Laura found a great one, where it's like a little bit faster than most protocols that I've seen and even brought with me for today's discussion.
Mm-hmm. It started a debate earlier.
And it did start a little debate. But it's not that the protocol was wrong. It's just that
it surprised you more than anything.
It surprised me because it's not what I was used to, nor what I was taught.
Yeah. And I've seen it used.
So it's a matter of And I'll never agree with like what protocol being like a one size fits all for everybody, because you
totally
have
agree.
comorbidities, you have different lifestyles, you have different levels of even motivation that can affect how fast you'll proceed through the protocols. So having a criteria for advancement was better than having like, oh, at week 1 do this, at week 2 do this, because it's like not everybody might hit that mark at that time.
And like I like the time frame because it gives you an idea of definitely like where the patient should be at or close to. And if you're like a week or maybe even 2 behind, it's not as big of a deal. But like if you're, you're supposed to be ambulating without crutches by week 3 and it is week 6, we've got an issue. You're either a big baby or something further is going on.
And if they go back to their follow-up and they're still in crutches, when they're not going to be, that doctor is not going to be happy.
No, but like, and so like, I do like the fact that we have these ranges in time, but I like the criteria aspects of protocol. And I feel like that's something that doctors should give. And honestly, I think doctors should give their patients their protocols. Like, I think doctors should, that's their plan. Like, you are agreeing to a plan of care. And you're, just like we talk about, goals are so important in general, like in our field. We have a goal for everything. And that's how we prove to the insurance that, we're benefiting. But that's also for the patient, too. Like, if they know their goals and what they should be gearing up towards and what's expected of them, like, yeah, we can talk about it, but, like, them physically having it and seeing it sometimes, I feel like it'd be beneficial. And I can tell you, like, right off the bat, like, when I had my Achilles surgery, like, I didn't know technically, like, okay, I knew from my own background.
After your first one? Or, well, no, after your other injuries,
general,
got it.
Yeah.
I thought even after your second surgery, or after your first surgery.
Just in general, from my background, I knew what the protocol pretty much was for ACLs. But, like, if I didn't, like, my husband didn't, if I wasn't in the background I'm in, I would have no idea what I was really getting myself into. Besides the fact that you might be able to go back to work at 3 months. But I
think that's a good point, because I feel like we have a lot of patients that have these surgeries and they don't know where they should be at. Mm-hmm. So I think one of the PTs that I worked with, he did a great job telling the patients, like, hey, by the end of next week, this is my goal for you.
Yeah.
Let's stop using crutches. Let's increase the the range of motion restriction. Like, as a doctor allowed it, like, hey, we got to build up to this. So our goal is to be at that by the time you see your doctor again. But, like, let's progress to this. Like, this is our goal this week.
Let's do 5 this week.
So by the time you see your doc, you hit the goal that he wants you to be at. Because a lot of these patients don't know.
They don't.
They're just I just know I was sent here and that's it.
I agree. Like, it should be on us too. But I think it should be something that is given in a way. Like, that's your preoperative care.
Post-operative?
Yeah, that's what I meant. Post-operative care.
I think that's what you said.
No, I think I said pre.
I was trying to give you the benefit of the doubt.
Nope. But, like, I think they should know. But it's, again, it's a whole nother debate within the medical community. And ultimately, of course, it's not our choice. But I think that's something that we can discuss with them while in the clinic. Of like, hey, this is, and we should, I know I probably wasn't good at setting goals for patients. And I think that's such a good thing to do. And moving forward, I probably will do that because I like that. Whether it's a shoulder, knee, low back. Like,
sure, it doesn't matter what it is.
My goal is for you to be able to be in less pain for 5 minutes throughout the day.
Right? It doesn't even have to be like an active thing. Like, it just has to be a milestone that they can aim for. Yeah. And so, that's kind of like, I definitely like the ones that have more of the advancing criterias, because it lets you into the doctor's mind a little bit more of what they actually want, versus just like what you can do, if that makes sense. Like, I know what I'm now building up to better versus, just do pulleys. That's like, and ultimately it falls down to the surgeon and what they give you, and you just have to abide by it, even if you are more conservative or you're more forward thinking. I mean, I don't want to say forward thinking. It's more like
new age, just more
aggressive.
Yeah, but I don't even think it's aggressive.
No.
It's just
I don't
not
know,
as
like
conservative. It's not
fast-tracked.
even like conservative is not a bad word, but just not as conservative.
Yeah.
Like you're conservative, but you're just not going to be like, let's put you in bubble wrap. And then, maybe we'll let you out after 6 months.
Maybe.
Maybe.
If you are
and
behaving.
The thing is, too, is with the ACLs, we do see quite a few injuries after post-op. So studies have been done, and they found that people who have ACLs have another injury. It doesn't even have to be ACL related, but have another injury within the first year. Now, parts of me just wonder if those players are just super aggressive, that they just get injured all the time.
Injury prone.
Who knows? I feel like I'd probably be one of those, and it would be completely separated from the two. But, we do see that. And parts of me wonder if it's almost because leading up to it is almost too conservative for them to return to play in a way. So
Just to avoid that re-injury?
Yeah. Like, for example, I'm a great one. We all know I've had plenty of surgeries, but I had a knee surgery. And I was partial weight bearing, 50% partial weight bearing. And then I was allowed to discontinue the crutches. And being in school at that point, I was not 50% weight bearing. I was full weight bearing on that knee. And I was talking to, at the time I was in my kinesiology program, and one of our athletic trainers, our head athletic trainers, was teaching a course. And I was like, I get to get rid of these crutches. And she goes, no, you still have tomorrow. And at this point in time, I'm legit walking on it. Like, it wasn't a beautiful ambulation, but I was walking on it. And she's like, if you don't show up to class with your crutches, like, you're busted. I literally came into class dragging my crutches behind me.
Not even using them.
Not even using them. I literally just had them dragging on the floor, and I was like, I showed up with them. And I was like, it was a day different. I was such a, still am. But like, it was a day difference. A day. Like, that's where I feel like sometimes those protocols get too strict, and that actually can cause a re-injury because we're almost babying it too much, if that makes sense.
It does, because just to reference that article yet again.
It's a good article.
Right, you're agreeing with it. You should read this article a little bit more in depth, because you're agreeing with a lot of points here. So they were saying that because we never do the open kinetic chain and we never strengthen our quad because of the fact that we're just babying the injury, that it's actually going to lead to more injuries.
Yeah, I can see that.
Because you never fully developed the strength that you were supposed to, because you depended too much on the co-contraction closed kinetic chain exercises.
I 1,000% agree with that, because you can't. It's so hard to isolate at that point in time. You have a muscle group versus a muscle.
Correct.
Yeah. So, I 1,000% agree with that. I'm not gonna lie. And then one of the other things we debated. Well,
you actually kind of already brought it up.
I did,
in a way.
But this is the hot debate.
This is the hot debate. We're not even talking about weeks anymore. So it came up at work. At what point should therapy be replaced with athletic training for them to return to sport?
Oh, I wasn't talking about that part.
What were you talking about?
I was going to say the hot debate was also, what's the definition of return to sport?
If you want to do that first.
Let's do that one first. So, to me, return to sport is when they are going back to practice. They're no longer sitting at home. They are back at practice and performing some sort of physical activity. To me, that is their return to sport. Now, that does not mean that they're fully returned to sport, or as I liked one of the articles I said, unrestricted return to sport. So I like the term that I think we should adapt in general within the field is there's restricted or limited return to sport, and unrestricted return to sport, I think would be a great way to define it, because the debate was, for example, running came up, and Ken was like, well, everything I see is like 9 months. And I was like, well, you start running before 9 months. The soccer player runs.
No, return to sport 9 months.
That's returning. But that's what I'm saying. Like, if you're running before 9 months, and that's towards their activity anyways at sport, they've already returned to sports before that 9-month mark.
So for me, return to sport was more return to sport specific drills.
Mm-hmm.
So not necessarily, oh, return to sport. Okay, let me go do some chest presses and shoulder press. Like, to me, that's just return to like conditioning almost, return to training, but not necessarily returning to their sport. If they're a basketball player, returning to sport would be like, okay, let's go run suicides. Let's go do weaving. Let's go do like just general sport related drills. So when I think of return to sport, it's like you're about to run drills meant for your sport, not contact, not full games, not anything like that. But you are essentially doing things that are meant for you.
Yeah, and to
not
me,
things that you can just do at a gym.
Return to sport is when you're going back to practice. You're part of that team. You're returning to your sport.
So that's why I thought it just took a little bit longer than just return to sport and let's go do some things at the gym that have nothing to do with your injury whatsoever.
Well, but that's my point was with soccer and running, for example. You could return to practice and start running before that 9 months. So would you say if they went to their soccer practice and they were just doing some running drills, not intense, but running drills that they're allowed to do, they already started in physical therapy, but they're not at that 9-month mark. Have they returned to sports? You could have done those running drills in the gym, but you're doing it with your team and you're at practice.
I mean, it could be considered return to sport.
So that's what I'm saying. Like, I feel like it's just not a clear definition of what's return to sport. To me, once you are okay to go to practice and do any sort of activity with your coach or team, you have returned to your sport.
Do you think
it's restricted return to sport.
Do you think they still need their therapy?
Oh, yeah.
Do you think there's a point where you should hand them off to the team to let them handle the rest of their rehab? Where it's like, hey, they're running, no pain, their range of motion is good. All we need is sport-specific drills that he needs to return to playing with you guys. I'm not going to give you the go-ahead because that's the doctor needs to give him the green light to actually play again. But just like, hey...
Well, that's the tough
They no longer need us because doing like a football drill for like a lineman, okay, we can do like, just get down into your 3-point position and quickly stand up. Or let's do some lateral stuff. Like things that they would do, but we're never going to give them drills like they would at practice.
That intensity. I definitely think if we're at the point where like they are gaining fully to return where it is no restrictions, maybe besides like contact in a way. Because, like, contact is, like, one of the biggest, one of the last restrictions. That and cut and pivoting. Or, like, one of the last ones to get lifted, would you say?
Yes, because I mean, at that point, you're returning to the actual, like,
so, like, I kind of think, like, leading up to that, yes, the hard part for me is, this is where it gets tough. Being a college athlete, and being a club athlete pretty much my whole entire life, I swam club, USA Swimming. Club didn't have an athletic trainer. So anytime I got injured, I was going full with swim. I mean, with physical therapy. And then they were clearing me to return back to swim along with the doctor. Or the doctor's orders would literally be once physical therapy clears you, you're good to go. I wouldn't even have to do a checkup at that point. He's like, you're good on my end. It's just now rehab. Like, once they clear you, you're good to go. But then I also had knee surgery in college. And when I was in college, it was straight up, and this is probably a lot of the cases too, I did rehab when I was at home. But once I went back to school, because it was during winter break, I switched over to the athletic training staff. Now, my surgery wasn't actually too much of sports related. I definitely think I actually could have gotten better. This is sad to say, but better rehab if it was actually with physical therapy, because athletic training was so sports focused in a way. It made it tough. But I think it depends on your facilities. and where you're at, what life stage you're at. Like, if you're a youngster and you're playing club, like, I wouldn't hand you off to anybody, even a high school athletic trainer. No offense.
Wow, that was oddly specific.
Well, my high school athletic trainer was literally a science teacher.
Huh.
Yeah, at that time they didn't require.
Credentialing.
But nowadays that could have changed, honestly. It could be a credential one. And when you're more of returning back to your normal practice and your restrictions are really low and I don't need to clear you off for anything, then yeah, I'd probably hand you off to the athletic trainer to take over. To me, I think it just depends on the kid, the parent, the support staff that they have. If you're returning to sports and you're gotten that far along, I'd probably let you hand off to the athletic trainer because A, it's cheaper. The parents aren't having to pay insurance to come to PT anymore. I don't know. It just, I think I don't have a clear answer, I guess is my point.
Yeah. And I feel like it is hard to have, like, at what point is it easy just to kind of hand it off? Because we can't make the decision for them to be able to play again and to return to sport, like, in that way.
We can't, no.
No, even the PT can't.
Unless doctor's orders. I was about to, well, in ACLs, yeah. But
it's a doctor's order.
When I had my surgery, the last time I saw my doctor, I had, I think, a checkup at a 2-month mark after post-op.
Mm-hmm.
And his orders were continue with physical therapy, no follow-up required with MD, physical therapy to clear to return to sports.
So in other words, the doctor did give the green light.
Yes, exactly.
But like
the doctor will give therapy the green light to say yes or no. It's just iffy on the doctor.
But like the PT couldn't just all of a sudden just decide, oh, you're good to start playing again.
Not fully.
No.
They can advise, but
correct.
They can't.
They can make the recommendations, but the doctor is the ultimate deciding factor on whether or not they can actually play or not.
Or the doctor needs to hand over the deciding factor.
Or hand over the deciding factor, but that's the doc.
Yeah, that's the doc. But when it comes to athletic training, I think it just depends. It depends on so many factors. Like I said, my athletic trainer wasn't certified. So I guess that's why I said when I hand over to the high school one. But nowadays I think they have to be.
Yeah,
so
I feel like
it's
you're
like
holding
a totally
like
different
a grudge from a very long time ago
that
just came up, and you're like, I'm gonna.
It's not even a grudge. It was just
now.
more of a like. I'm like, knowing that he wasn't certified, I wouldn't hand him off an ACL post-op. Like, that's not going to happen. But now I'm like, I think they're actually all required by law to have it. So I don't know. That would be an interesting thing. But I think it just depends on the patient, where they're at. And the thing is, too, is if you've gotten that far with a patient, sometimes they don't want to be handed off.
I just think it's like hard to provide their game-specific stuff.
Yeah.
Like we're in a facility. We're not on grass for soccer players. We're not on a football field for football players.
And you can't take them out there either.
And we can't take them there. So it's like we can't give you real life scenarios in therapy at beyond a certain point.
Yeah.
So as long as, everyone's okayed it, then down the road it is better for them to start working more with their team. But granted, they hit all their milestones. There's no pain. Everything is good on the PT side of things. The doctor's all good. Now it's like, okay, we just need to hammer your sports stuff.
I think I definitely would feel ready once they hit return.
Because I've had a couple patients. Like I think we had a baseball player once and a football player, and we're just like,
we're running out.
We're like trying to wing it as best as we can with like, let's do like base running drills for the baseball player, like quick turns, like pretend like you're running the first and then quick step to the left, like drills like that. For the football player, I think he was the lineman, so we had him go into his stance and pop up really quick. And I mean, it was all, the best we can do with what we were given.
Yeah. No, that's a good
but it's
point.
not going to be anything near. And like they had no pain. They were all good to go. We just had to try to push them more specific for their sport.
Yeah, and parts of it too is I even think like when I return, really what happens with some of that when they get that far advanced is they return to doing those activities within just their practices, but they have standby of athletic trainers usually watching them too, who are visually like, hey,
observing them and seeing.
You don't look strong enough to do that. I need you to back off. Do you have pain with that one? Back off of that one. Like who's there a little bit giving that guidance through the practice. And I think that's the way it should be. You should have someone at your practices looking out for that stuff.
Yeah.
If that makes sense. Because there's just no way to imitate a practice, honestly. Just like you can imitate a full game, but you're never going to actually experience, like, you can't be, like, fully game ready until you're in a game, if that makes sense.
Exactly.
Yeah, so. But that was kind of it on ACL protocols. I know we didn't dive too much into some of the exercises, but we wanted to just talk about, like, the research and things we've seen and just some of the other discussions that came up on it.
Yeah, there's so many different protocols that it's hard to just pick one, because you're between different surgeons, between different universities and different practice guidelines. You're always going to find a different set of protocols.
Agreed.
So kind of follow what your surgeon says, and if the surgeon doesn't give you one, then ask your PT what protocols they want to use and go from there.
Yeah. Yep. I couldn't have said it better.
All right. Well, if that's all you had, that's all I had.
I think that's about it for at least this episode. I got plenty more for more episodes.
All right. Well, be sure to follow us on Instagram at the PT Assistants. We also have a YouTube channel where we post every other week on Saturdays. Be sure to check those videos out, and we are always welcome to some feedback if you guys would let us know if you guys want to hear anything in particular. We thank you so much for listening if you've made it this far, and we have much more to come.
All right.
Hope you guys have a great rest of your day.
Bye.
The information in this video or podcast is not intended nor implied to be a substitute for professional medical advice, diagnosis, or treatment. All content, including text, graphics, images, and information contained in this video or podcast is for general information purposes only and does not replace your professors or a consultation from your own doctor or healthcare professional.